my disclosures. None are relevant to the content of this talk. So the first question after treating an Achilles tendon, whether that be surgical or non-surgical, is if they're weak, why are they weak? And here are some of the potential reasons why that may be happening. Did they not participate in their rehabilitation or have insufficient rehab? Is this an actual anticipated outcome and we just didn't talk to them enough upfront about that? Has a patient had a re-injury or re-rupture? And then the topic I'm going to spend most of the time on is a deep dive into Achilles tendon elongation. So whether that's from progressive lengthening postoperatively or a lack of proper tensioning initially in the OR. This is just a brief note on creep. So creep being an increase in length over time with a constant load applied. So just to give us a little bit of a background on the pathomechanics of what may be happening to the tendon. There are many, many studies looking at Achilles tendon elongation after treatment with lots of long discussions about creep. We won't go there today. But after Achilles tendon treatment, there are some, patient factors that we have identified as risk factors for poorer outcomes, including increasing age, increasing BMI, and then at the other end of the spectrum, patients with a higher pre-injury activity level. There are a tendency in the literature to be fewer reported symptoms after surgical treatment when compared to non-operative treatment. But measurable postoperative weakness is an anticipated outcome of Achilles tendon rupture treatment, whether that be operative or non-operative. This is especially when the patient's positioned in 10 and 20 degrees of plantar flexion. The studies are somewhat variable, but on average, it's a 12 to 35% difference in plantar flexion strength that's been reported, especially those end range deficits. So we'll dig into this a little bit further. The second thing that is expected is decreased passive dorsiflexion stiffness. So my recommendation based on this alone is that preoperative education, that restoration of normal strength is actually not anticipated, but it seems that for most activities, the strength achieved is adequate. I thought this was a really neat study by Hynes in 2017 looking at the anatomical outcomes after Achilles tendon treatment. And on average, it's really important to know that the Achilles does tend to be about 12 millimeters longer after rupture and treatment compared to pre-injury. And so the clinical outcome of Achilles tendon treatment is related to that magnitude of elongation. This study looked at side-to-side difference of the muscle cross-sectional area after treatment, and there is a difference. The gastroc and soleus cross-sectional area was about 10 to 13% smaller, while FHL may be trying to help compensate with about 5% hypertrophy compared to the non-injured side. And the important thing to know, I'm not here to debate non-operative or operative Achilles tendon treatment, no interest in going there, but elongation of the Achilles tendon does occur regardless of treatment type and regardless of rehab protocol. There have been many studies looking at different early weight bearing, different variations on the protocol, but elongation still happens. And so I mentioned that the previous anatomical study noted about 12 millimeters of elongation. There's some variation in the reports, but 5 to 11 millimeters of that elongation seems to occur in the early 6 to 7 weeks, but it's been established that the Achilles tendon can continue to elongate up to 6 months after treatment. And this one study that looked at that very specifically, about half of the total elongation occurred in the first 3 months. There's several studies that noted there might be slight shortening beyond 6 months up until a year. But again, these rates of elongation and timelines of elongation were not associated with a particular rehab program. And so why does it happen? Probably it goes back to that creep concept, but there's potentially some surgical factors that play into the degree of elongation. Is there gap formation at the tendon repair site, or knot slipping or suture material creeping as well? This one study tried to do all of the things that the literature suggested to make it the strongest repair possible, which was a 4-strand crack with epitendinous augmentation, and they found the exact same deficits in weakness when compared to the previous literature. This is a summary of the technique recommendations that are out there, suggesting ways to reduce this postoperative weakness, freeing adhesions, using large caliber non-absorbable sutures, knots away from the rupture site, epitendinous sutures, but this elongation still seems to occur. So if you have non-operative treatment of your Achilles tendon rupture, the elongation tends to be gapping either at the time of treatment initiation or the tendon healing in a lengthened position with progressive lengthening with rehabilitation. And then there's been many studies looking at how you measure how long the Achilles tendon is. So is there increased passive ankle dorsiflexion clinically? Is there an absence of resting plantar flexion? There's been a lot of work done on the Achilles tendon resting angle, which I'll talk about, and heel rise height. People have done ruler measurements, done it based on imaging with X-ray, ultrasound, and MRI. But it really still comes down to that it is longer after injury. Interestingly, if you want to correlate dorsiflexion, passive dorsiflexion, to the amount of lengthening, passive dorsiflexion increases by about 12 degrees for each centimeter increase in length of the Achilles tendon. And this is that measurement I referred to as the Achilles tendon resting angle, is by far the most commonly used metric in the literature to look at Achilles tendon length. And this is how you measure it. But basically, the injured limb is more dorsiflex than the uninjured side, with the patient in a prone position with the knee bent. This is the second measurement that's reported quite a bit in the literature, is this heel rise height. So you're looking at the maximum rise of the heel compared to the uninjured side. And usually there's about a 3 to 4 centimeter difference when comparing that after injury. So all of this said about Achilles tendon length, does it actually matter? And the answer is yes. So if a muscular tendinous unit is overly lengthened, the muscles have to contract more to produce the same action. So an increased atra has been shown to correlate with a loss of plantar flexion strength, which leads to decreased power and endurance. And clinical measurements of tendon elongation actually correlate with patient-reported outcomes. So postoperative Achilles elongation leads to poorer plantar flexion strength. So I would say the recommendation after all of that said is anticipated lengthening and the tension of the repair. And then there are folks who are advocating to repair the Achilles tendon as tight as possible in anticipation of that expected lengthening. There's non-surgical treatment of elongation, of course. We always should exhaust this, especially if the main problem is that the patient didn't do the rehab to begin with. So the goal is to strengthen primary and secondary plantar flexor muscles and proprioception training. And then operative shortening is really the treatment that's described for this problem. So there have been a couple small studies looking at operative shortening of the Achilles tendon, which show decreased gait disturbances and improved activity participation. But there is persistent measurable plantar flexion weakness, even despite shortening the Achilles tendon. The nice thing is, if you're doing a shortening procedure, it's less frequent that you need augmentation in treatment of these. So several techniques described. End-to-end repairs is described. I'll show you a couple pictures of that. Z shortening. Mini open and percutaneous was described in one study I found, and then augmentation only if required. So end-to-end shortening was really described for untreated Achilles tendon ruptures, but this is where they incorporated the fibrous scar tissue in the repair of the Achilles tendon. And Mafuli et al. Looked at Z shortening or Z shortening, depending where you come from, tenotomy, which increases the healing surface of the Achilles tendon. And for this technique, they had the ankle in full plantar flexion, resected the opposing strands, and completed the repair. They had decreased peak torque still, despite all these efforts to restore strength, but it was not interfering with the patient's activities. Just to clue up, because we're short on time, augmentation, most people in this room know lots about all the augmentation techniques, but basically if in removal of the prior repair material, there's not enough Achilles tendon tissue for a strong repair, you may need to follow your algorithms for a tendon gap. Very brief note on re-ruptures is not the focus of the talk, but in re-ruptures, there's a slightly favored to be reduced rate with surgical treatment. There's reduced rates with functional rehab programs. And more often, a re-rupture is treated operatively than non-operatively, with advanced imaging typically being recommended. And the treatment of re-ruptures really just goes down your treatment of an Achilles tendon gap algorithm with augmentation as required. There's a nice algorithm by Burlett and colleagues about re-ruptures, and then I made up my own for Achilles weakness post-rupture. It's a little more simple because there's not a lot of operative treatments listed there. Thank you very much.